Thank you, Dr. Parag and Dr. Narendran, and the opportunity. This talk is going to be fairly different from most ROP talks that you've heard and also most ROP talks that I usually give. It is usually more clinical, how to treat, how to follow up, how to image, even how to do other kinds of imaging. But suddenly we are talking now about vision rehabilitation, which in itself is a subspecialty. There are masters and PhDs, and in fact in our institute there's a separate department. But why is it important for us as ophthalmologists, especially people interested in ROP? Because even now there is bad outcome, either unscreened ROP or, to our best ability, as Dr. Azad said, a few percentage will recur, will detach, and then you simply can't say that, wash your hands off the patient and say nothing else can be done. So this is mostly to give you some sort of an overview of the principles involved in rehabilitation, and if at the end of the day you know what to look out for, what the red flags are, which baby could possibly need vision rehabilitation, and when to refer to a rehabilitation specialist, then really my job is done. I have no financial disclosures. So I just put this out because this talks beyond ROP. If you look at the causes of blindness in the world, India and China are so big they have one vertical of their own. And about 1/5 or almost 1/3 of those causes of blindness cannot even be treated, let alone prevented. Of course, we know ROP is the most preventable cause of blindness, but then if 24% affects the globe, the entire globe, and you have microcornea or microphthalmia, what are you going to do? So that's when rehabilitation plays a really important part. So what is our role? We are in the habit and in the business and in the practice of treating these children, and we're encouraged by the smiles they have, but behind that there are these blind eyes, and I've put blind in inverted commas for a reason. They're not really blind. It is as functional as that retina and the visual pathway can see. And it is not even an end road like an adult. In a child, 80% of what the child learns and all the milestones that the child picks up in the first 2 years is picked up through vision. So if the child cannot see the ground, he will not really walk, and so gross motor milestones may be delayed. If he cannot see an object, he will not pick the object, so fine motor will be delayed, and unfortunately he may get misdiagnosed as autism or cerebral palsy when all he needs is vision rehabilitation. So 80% of vision actually dictates other milestones, and so we have to work in conjunction with the pediatrician. Now, these are very complex pathways, but one thing that I've underlined there is visual anticipation. The ability of the brain to put vision above anything else in development in the first 1 or 2 years, that's really the anticipation of the brain. Yes, there you can open a textbook of Nelson and decide what kind of milestones a baby should reach, but it's important to assess the entire family. Now, the dynamics of a vision rehabilitation child has to be assessed in context with the parent. And even if the child has a really small retina that's functional, if the child does not use that retina, he's going to lose the function. So firstly, this comes from pediatric developmental textbooks, not really ours. So there are children who are social, some who are reluctant, some who are almost on their own, and these are the ones that are often misdiagnosed as attention deficit hyperkinetic disorder, and finally the passive. But more important, because we don't know how to assess children, we must know how to assess the parent, and I think these are the ones. And as a parent, they are extremely anxious, and they have often come to you after they've probably gone to many other places, and they have a lot of hope in their eyes, so one must listen. And before categorizing and being judgmental, it's important to decide what kind of a parent and what kind of counseling they would need. Some need just to be listened to, some want to be explained, some want some drawings, some want you to go through their entire file. It's important. And then for developmental specialists, there is a big difference between a delay in visual maturation and a dissociation. Just like in statistics, more than 2 standard deviations would be a delay, and less than, there is some amount of delay, but not as high as 2 standard deviations. They are treated differently. And yes, as I mentioned, you have to really assess all of this. It's a good idea sometimes to go to a developmental clinic and spend a few hours. We get the hang of it. All of us have passed through internship, but it's different assessing a challenged child. These are just bad pictures of ROP. some that could be treated and some that have gone bad. And even the so-called good outcome ones with the angiography, we know that their foveas are not really the best potential, even though the foveas are perfused. As a clinician and as a person who's probably treated these babies, you should know which part of the retina works best. If it's not the fovea, is it extrafoveal? Is it in the superior retina or is it in the nasal retina? If you don't make these points clear in the discharge summary or the referral letter to a rehabilitation specialist, they are not going to know. Now, even in this partially attached so-called better outcome stage 5 surgery, the child will have certain parts of the vision better preserved than the other parts. And it is you as the clinician, maybe the operating surgeon, who should decide what happens. So when they've lost hope, you must not tell them that that's the end of the road. So when I was doing my fellowship in the US in pediatric retina, this is what really inspired me. The apartment that I stayed in was actually a rehabilitation center. So whereas it was my home in the night, during the daytime they use it as rehabilitation center, and there are these experts who really come in, and the entire residence apartment is keyed in for a visually impaired child, including keeping small mirrors at the edge of the room so that when the child is crawling, doesn't go and hit himself against the wall, sees the reflection and turns around. Small but really important things. And closer home in Chennai, I've been really inspired by the work of Dr. Namita Jacob, who works very closely with Leah Hevarinen. All of us have heard of the Leah symbols, and she's been guiding our program for over a decade now. So that's Leah in 2008, and we actually had the honor of having her just 2 months ago, almost 10 years later, to guide us again. So this is the project that we call a Steady Mile Towards Sight, and that's our rehabilitation program. I don't really want to go into the details because it's far more beyond what us as ophthalmologists can even begin to comprehend. So I'll just go directly into what kind of principles of therapy they have. So firstly, it's ideally a week-long program where they are sort of first you familiarize the baby with all. No, these are simple-looking toys. In fact, in Karnataka, we have a town called Chenpatna, which makes these wooden toys which are apparently toxic-free and handicrafted. We get most of our stuff from there. Now, these look like any toy in any child's playroom, but they are chosen for a reason. And there are colors that a visually impaired child will process better than something else. For example, a red and a green is supposed to be better transmitted through the optic nerve, and blues and yellows go better through a macula. I mean, this is conventional technique. But when you look at a visually impaired child with a detached retina, red, blue, green, yellow is the same. So you have to begin with high contrast and then move to colors. Then, of course, as I mentioned, speech and language, art, this is something that, so these are not just areas of development, but also areas of therapy. I'm really going to go fast on this because I want to talk more on the clinical angle. But the best part of doing all this is that we want them to integrate to what they call ADL, and this is a term that rehabilitation specialists will use, which is activities of daily living. Can the child wake up and brush his or her own teeth, wear her own clothes, comb hair, walk to the dining table, and so on. So all these things have to be taught. It is not something that the brain will learn just like that. And I think the entire focus then changes from the baby to the family, because you have to bring the family in. So let me show you, this was that partially attached retina that was operated. So this is a stage 5 surgery, and that's actually, I think, Leah's hand. Unless you tell the rehabilitation specialist which part of the retina is better functional, now you can see the child is grasping, figures out where that is only in a particular quadrant closer to the mother. So that's because the right eye nasal field is better preserved, a little more attached. So the temporal retina is a little more attached. Now this you will know as the ophthalmologist, as the ROP specialist, you need to communicate this. And then there are, of course, VEPs and standard objective ways to figure out what you're doing is right. This is a baby who was operated at the month of 22 months. Now, look at this video carefully, and you will see that the child is smiling after a certain time. Now, this child actually came from Sri Lanka, was already operated. We sort of did a resurgery, and somewhere there is going to be the smile. Yes. And I think that's important because we all know a social smile is supposed to come at 3 to 4 months. But this was a 23-month-old baby who had apparently smiled for the first time. And this is what the father said. And he really broke down because that for him was more important than the child. He knew that the child is not going to go into a regular school and probably do regular education, but he wanted a normal child whom he could relate with, and that's what rehabilitation does. It's not the surgery, it's not the laser, but it's bringing the entire family together. And I think you can show that objectively how it works with the cognition, the language, and the social improvement, and you can see the amount of improvement that happens after. The one thing that you have to remember is these 4 or 5 points. Hypoglycemia, more and more common in our era, especially if you have a lot of babies in your outpatient waiting to see you for ROP screening. Remember, hypoglycemia can affect the visual cortex. Even if the child, so there's something called a symptomatic hypoglycemia and just a hypoglycemia. So hypoglycemia can affect 16% of the visual cortex, and they will have visual impairment almost permanently. But if you have, by any bad luck, that hypoglycemia is causing the baby to have a seizure, then that's almost a 60% chance of a child having a cortical visual impairment. And I think that is so iatrogenic if the child throws a seizure in your outpatient. So all of us who are involved in ROP screening will invariably have a feeding room and encourage the mother to feed. Because if in the hope that your child is going to be seen a minute or few minutes later, and with the dilatation, all that delay, hypoglycemia is really important. The other one is intraventricular hemorrhage, and this was shown as a single important factor in a very large longitudinal study from the United States to have a very big impact on vision and in outcome. And kernicterus, which is really bad gone jaundice, where it's really the bilirubin crosses into the brain and affects parts of the basal ganglia. This could be bad in terms of vision as well. And of course, the large field of birth asphyxia and cortical visual impairment, which I didn't even want to get into, because CVI itself is a separate thing, and I think there's an instruction course on that separately. So these are the things as clinicians who are dealing with preterm babies in ROP should remember. But let's remember that early intervention truly starts early. It's not after your surgery, whether you're doing pediatric cataract surgery, glaucoma surgery, or retinal detachment surgery. The moment you know the child has a possible challenge for vision impairment, that's when the vision rehabilitation starts, and that's when you should be referring it to your rehabilitation specialist or develop the team within. Thank you very much.